adenomyosis, and today I'll be talking about adenomyosis. Adenomyosis, like endometriosis, means there is implantation of endometrial gland and stromal tissue outside the uterus, whereas in adenomyosis there is implantation of endometrial both gland and stromal tissue within myometrium. That is called adenomyosis. So definition is adenomyosis is a condition where there is ingrowth of endometrium, both stromal and glandular component directly into myometrium. It is a benign ingrowth of endometrium into the myometrium. It is never malignant, similar to fibroid uterus and endometriosis. It's a benign condition. So here both glandular and stromal component of endometrium are involved. Causes are unknown. It's usually not known. However, it is suspected that causes may be due to repeated childbirth, due to vigorous childbirth and excess of estrogen, vigorous dilatation and curettage, and excess of estrogen effect. That is considered as a cause. So pathogenesis is there is extension of endometrial gland and stromal tissue beneath the endometrium myometrium interference. There is one layer called a junctional layer between endometrium and myometrium. Whenever there is disruption of this layer, then there will be chances of adenomyosis. So the thing that causes disruption of this junctional layer would be repeated childbirth, in which there is shedding of endometrial tissue, and in case of vigorous curettage, probably due to trauma, there will be disruption of this junctional layer, and because of disruption of this junctional layer, there will be direct implantation of endometrial gland and stromal within the myometrium. So in case of trauma and vigorous childbirth, there is submucosal layer is absent, and endometrial gland lie in direct contact with underlying myometrium, and thus there is direct implantation of endometrial tissue. So there will be formation of endometrial foci around the myometrium. So like I have already said, there will be disturbances in junctional layer due to genetic, endometrial factor, and altered immune response. These are additional causes that will lead to disruption or disturbance in junctional layer. So this is a normal uterus, whereas in adenomyosis there will be implantation of endometrial tissue within myometrium. It may be diffuse enlargement, diffuse implantation, and there will be diffuse enlargement of uterus, whereas in some case it may be foci. Small endometrial foci can be formed. Both are considered as adenomyosis. So pathology is there will be enlarged uterus. There will be asymmetrical enlargement of the uterus, and the adenomyosis endometrial tissue is more seen over the posterior wall. Size usually is not more than 12 to 14 weeks of gravity uterus. This is one of the distinguishing factor for fibroid uterus to adenomyosis, because in fibroid uterus mass could be more larger than 14 weeks, whereas in adenomyosis it's usually less than 14 weeks. So on cut section, there will be thickening of endometrial wall is seen, along with trabeculated appearance. And another factor distinguish between fibroid uterus and adenomyosis is, in fibroid uterus there is capsule, whereas in adenomyosis there is no capsule. So this is the cut section of fibroid uterus adenomyosis. Here you can see that there is diffuse enlargement of myometrium. In case of fibroid uterus, we can see there is multiple capsulated mass, whereas in myometrium, you don't see individual mass, but there is diffuse enlargement of myometrium. So on microscopy, we see glandular tissue surrounded by stromal layer in the myometrium. Ectopic endometrium, which is separated from the underlying basal endometrium, are seen, and which is located in the deeper than myometrial junction, which is seen in high power field. And invasion is mainly over the basal layer. Clinical feature. Usually, it is 1/3 of the cases asymptomatic, whereas most of the patient, among symptomatic also, most of the case present with complaint of menorrhagia. There will be excessive bleeding, PV for vaginal bleeding, irregular bleeding. The causes for irregular bleeding are, okay, I will talk about it later. So usually it is asymptomatic, which is detected on routine examination, and the patient are usually in their 40s. History of obstetric history shows they are multigravida, and one of the differentiating factor between endometriosis and adenomyosis is endometriosis is usually seen in nulligravida patient, whereas adenomyosis is just opposite. It is seen in multiparous female. And sometimes, most of the time, it is associated with endometriosis. About 40% of the time, it is associated with endometriosis, and sometimes it can be associated with fibroid uterus. So like I said, usually among symptomatic patient, most of the patient will have menorrhagia. Causes of menorrhagia are due to increased surface area. As the uterus size is increased, there will be more surface area and during shedding from this enlarged surface area, there will be increased bleeding. So increased surface area and endometrial hyperplasia will cause menometrorrhagia. So it can also cause irregular menstrual along with menorrhagia, menometrorrhagia, and prolonged bleeding. And another common cause is congestive dysmenorrhea. Like I said earlier, there will be disruption of junctional layer, that is layer between endometrium and myometrium. That is usually, which is regular, that layer is very regular in normal patient, whereas it is irregular in a patient with adenomyosis. So what happens is, in normal menstruation, there will be antegrade propagation of uterine contraction during menstruation in order to expel blood. So in case of congestive dysmenorrhea, this normal physiology is lost. And so most of the patient have cramping pain during menstruation. And some may have cramp throughout the month, aggravating during period. And this is also due to irregular surface area and disruption of junctional layer. Patient may complain with dyspareunia, mostly premenstrually, which is due to disruption in the normal physiology to contract uterus. And also patient may have dyspareunia because it is mostly associated with endometriosis. So infertility is also one of the factor. Infertility is also one of the symptoms. Patient infertility is usually secondary infertility because adenomyosis is mostly seen in the multiparous female. So there is irregular surface, disruption of junctional layer. There will be no implantation. There will be no proper surface for implantation. That is one of the factor for causing infertility. Along with that, because of irregular surface, it will hinder sperm motility, and the normal contraction of uterus is also deranged in adenomyosis. So that can also lead to infertility. So as the size increases, some patient may also have difficulty in maturation. So when we examine the patient, when you do abdominal examination, we see that abdomen uterus is enlarged, but it is not more than 14 weeks. Like already I said, this is one of the distinguishing factor for fibroid uterus with adenomysis. On pelvic examination, there is uniform uterine enlargement with no restriction of mobility, which again differentiate between ovarian tissue, fibroid uterus, and endometriosis. Uterus may be softer than normal, but however, finding may alter if it is associated with endometriosis, because in endometriosis there will be restriction. Sometimes there will be restriction of mobility, along with there will be tenderness, cervical motion tenderness, and rigid uterocervical ligament. For investigation, we can send routine blood examination. In routine examination, anemia could be seen due to menorrhagia. However, ultrasound is the first line of investigation we can do to diagnose adenomysis. So in ultrasound, we can see asymmetrical enlargement usually of posterior wall. In myometrium, multiple small cysts with increased vascularity and heterogeneous texture are seen. Endometrial myometrial junction, which is also known as junctional layer, is indistinct. And if localized, it can be misdiagnosed for fibroid. And sometimes adenomysis can be localized along with formation of polyp, that is known as adenomyomatous, which can be also seen through ultrasound. So in ultrasound, we usually see three distinct echogenicity of myometrial layer. Inner layer is usually hypoechoic as compared to middle and outer layer. Whereas in adenomysis, subendometrial halo is seen, heterogeneous echo are seen, three distinct layer is not properly visualized, and hypoechoic myometrium with cystic changes, honeycomb appearance could also be seen, and there will be increased vascularity due to thickened myometrium and increased stromal and glandular activity. We can see that there is enlarged myometrium, along with there is cystic change. This is seen in ultrasound. However, diagnosis of choice is, investigation of choice is MRI, which will distinguish or help in diagnosis of adenomysis. In MRI, we can see there is a widening of junctional zone, that is thickness more than 12 mm. If it is less than 8 mm, it will rule out disease. It will rule out adenomysis. So MRI will differentiate localized adenomyoma and fibroid. So in case of diffuse adenomysis, we can easily distinguish between whether it is fibroid or adenomysis. But if it is localized, it can be sometimes confused with fibroid uterus. So in that case, MRI could be helpful. This is also this is MRI of uterus. This is endometrial layer, which is seen as hypoechoic. What is in nature? What is shadow? Where this is serosal layer, this is your uterus, and we can see that it is thickened. This picture could be seen in MRI. So management depends upon the age and desire for future fertility. In case of secondary dysmenorrhea, we can prescribe OCP and NSAID. Generous agonists like danazol could also help. However, levonorgestrone intrauterine system, that is Mirena, is more effective than any other method. But medical management is not so effective, and the only treatment is total abdominal hysterectomy. So similar to management of endometriosis, what we do is we give medicine that will um, help to either decrease ovulation, or it will create the medical postmenopausal syndrome in similar to endometriosis. So if you give medicine that will help to decrease ovulation, uh, that will change to an ovulatory cycle, or if we are able to create medical postmenopausal physiological postmenopausal, then what happens is this gland and stromal tissue will subsequently decreases. So there is another term called stromal endometriosis. It is a rare condition. Here, endometrial stromal tissue without granular component are present in other places other than uterine mucosa. It is usually involved in broad ligament. Chances of recurrence is there, so it is usually considered locally malignant. Clinical feature is similar to adenomysis, and management is surgical in case if family is completed, and radiotherapy if patient want to preserve uterus. Thank you. Any questions? के छ सुन्नुपर्ने?